Okay. Next up, on the other side of the spectrum from fundoplication is MSA, magnetic sphincter augmentation. Brian Louie is going to tell us about how they never have complications.
I'd love to tell you that's true. Well, I'd like to thank Reg and Kate and the organizing committee for the invitation and the opportunity to be here at this meeting, like most speakers. These are my disclosures. The most relevant is that I do have research grants from Torax Medical, maker of the Lynx device. Like you heard yesterday from Dr. Bonavina, you heard all the good things. He told you that reflux is generally well controlled. There are a minimal amount of things that are going on, and generally it was simple to do. But I get to tell you perhaps the not so nice side of the equation. So there are several sites of potential complications when you place a magnetic sphincter. The vagal nerves, as you heard from Dr. Casket just recently, the esophageal body may be affected. You may have trouble with the hiatal canal. The stomach is potentially involved, and the device itself certainly can cause some problems, and I'll show you some examples of that. The incidence of postoperative complications or intraoperative complications for the Lynx device is exceptionally small. This is a series of examples of trials with more than 100 patients, which show that the intraoperative problems are actually fairly minimal. There was a couple bleeding episodes. In this one study, there was an enterotomy, and I was quite impressed that they had an enterotomy and still placed the Lynx device in, because I would have thought that would have been a relative contraindication. And then in the 30-day outcomes, there are just a scattering of various things that occur, but one of the things that does come out in some of these larger series is that there are anywhere from 2 to 8% of patients might get readmitted for nausea, vomiting, and some trouble swallowing after Lynx device within those first 30 days. I can't say that we've had that particular problem at Swedish, but we also have a good cadre of nurse practitioners who manage to stave these things off before we get them admitted. There have been several safety analyses over time by several of the authors, even in the audience. The first one was John Lipham's paper that looked at the first 1,000 or so Lynx devices, and he showed the intraoperative complication rate was about 0.1%, that the readmission rate was 1.3%, dilations at that time early in the experience were about 6%, the erosion risk was 0.1%, and device removal was about 3% at that point in time. And C. Dan Smith updated that several years later with now some 3,000 cases. He didn't report any of the other metrics that John did, but really focused on the erosion risk, which was situated at 0.3%, and a removal rate of about 2.7%. And then John's group again came back looking at just erosions with a very consistent erosion risk of 0.3% now in some 9,500 Lynx cases over time. We'll delve into that a little bit later in the talk. Is there any way to get that to stop?
Our screens are,
This just keeps flickering. Is there any way to stop that so that I don't have to keep looking that way? So one of the things about postoperative complications or problems with the Lynx device is really to look at why people remove the Lynx device, because I think that gives you a lot of sort of understanding of what's going on. And this is from C. Dan Smith's paper using the MAUD database. That's the manufacturer's database of 3,200 cases with the explant rate of 2.7%. And what you notice is that the most common reason to have the device removed is dysphagia. And that occurs in the first year, followed by reflux. And then the other things, abdominal pain, erosion, other, are actually fairly uncommon. And that the most of the devices that are being explanted in the MAUD database came out within the first year. If you go to the pivotal trial that Torax sponsored, a multi-institutional trial, you can see again that dysphagia is the most common reason for removal of the device, and that explant rate in that study was 7%, and then vomiting, reflux, and a scattering of other sort of symptoms got the device removed. When you go to a single institution study, this is Dr. Bonavina's series of 164. He had about a 6.7% explant rate. The erosions in his series were 2 out of 11. And the reasons for removal in his series were reflux. And he identified that patients who had supine reflux was one of the key risk factors for removal. If we look at this more carefully and a little bit more in depth, let's talk about dysphagia first, because this is the most common reason that people are talking about, and one of the things that's been highlighted by patients about the Lynx device. In the graph on the left, that is a multi-institutional series that I put together with John and and others looking at comparing magnetic sphincter augmentation to laparoscopic Nissen fundoplication. And in the box, you'll notice that dysphagia occurs, really moderate to severe dysphagia is about 14% in the MSA group, but it's not vastly different in the fundoplication group. And then on the box on the right, this is data from the post-approval study that was mandated by the FDA, looking at bothersome dysphagia. That's on the GERD HQL score of greater than 3, and you'll notice that that rate is somewhere around 8% at 1 year with difficulty swallowing compared to 21 up front, painful swallowing at about 4% over that 200 patient series. So common, but not that common to have bothersome dysphagia post-LINX device. In that PAS trial, we also looked at new onset dysphagia, so people who didn't have dysphagia coming into the trial and who developed dysphagia after the LINX device was placed. There are 82 patients who had no dysphagia preoperatively. 30 patients developed new onset dysphagia at the 12-month follow-up mark. And you can see there that on the graph on the right that most of it was noticed but not really all that bothersome. Some of it was noticed but bothersome, and a very few people had really bothersome daily symptoms of dysphagia. Of the 30 patients, dilation was required in 13, and symptomatic resolution occurred in just over 75% of those folks for 10 out of the 13. And a couple of them required dilation more than once, but most of it's one dilation, and they mostly got better. And so what we've learned about dysphagia post-LINX is that there's really an early postoperative period, and I think if you have good mid-level providers, a lot of this can be taken care of by them, and it usually occurs at about the 10 to 14-day mark after the device is placed, and we like to think that's related to encapsulation, scarring of the device. And for the most part, this is self-limiting. A lot of the LINX surgeons now treat it with rehab. We have them swallow regular food quite frequently every hour so that the device opens and closes, so that the scar that's formed around the device actually is pliable and functional. There are a small proportion of patients who might have refractory cases, and in that case, most people are giving a short course of a Medrol dose pack to see if we can take out some of the inflammatory component of that, and that usually solves the problem. Rarely in this early postoperative period do we dilate anybody at this point in time. The second component of dysphagia is those that are persistent, and a lot of it has to do, at least in the experience that I've had, is predominantly solid food dysphagia. And one of the first questions that I usually ask those patients is, well, how are you eating? Are you eating the hamburger in 30 seconds, or what are you trying to do? And if they're eating too fast, the first thing is to slow them down, have them chew their food better. Unlike a fundoplication where we have graded introduction of solids and food over time where they have to learn to eat, we put LINX patients on solid food from the get-go, so sometimes it takes them a little while to slow down. In this group, a lot of them, if they get to this point and they're still unhappy, dilation is sort of the next sort of step. And the Torex is recommended using a through-the-scope balloon dilator, and the Torex protocol says to go to 15 millimeters as a starting point. I typically have started at 15 and gone to 17 if I've had to dilate anybody, because I think not only you're trying to dilate the scar that may be around the device, but you may also be trying to dilate the hiatus, which is what we've closed when we've done the full dissection. And I think we're starting to see a little bit more dysphagia when we've had full dissection and we've closed the hiatus, because now we're getting scarring around that, whereas in the middle of the dissection days early on, we weren't closing that, so it wasn't as big a problem. I think we're also awaiting, several of us participated in Steve DeMeester's multi-institutional study where we've submitted data to him about the dilations, and I think we're waiting to see what Steve's research is going to show with that when we see that out. And if it's persistent, this is where further evaluation may be necessary, and you saw Dr. Pandolfino put up some very elegant algorithms about how to manage those things, and I think much the same way. We would start to evaluate those with manometry, a barium, to see what we think is going on. As the LINX device moved, is it migrated, is something else gone on? The one thing that I do worry about is late onset dysphagia. So if you've had a patient with stable dysphagia, it gets worse, or you've had a patient with no dysphagia, and then all of a sudden they have dysphagia, that is a marker, at least in my books, for an evaluation. And that evaluation initially was upper GI and endoscopy with or without a manometry, but more often than not now I include a chest x-ray and I get the endoscopy, because this is what I'm looking for. I'm looking to see whether the device is migrated into the chest, and I'm looking to see whether there's an erosion. And so we'll talk further about the erosions next. In the one safety analysis study by C. Smith. These were what we knew about erosions at that point in time. And what you can see there is that from a symptom standpoint, the most common symptom is dysphagia. And this was new onset dysphagia or worsening of dysphagia. Once in a while, it's after a retching episode. Some people got epigastric or lower chest pain. And you can see the device sizes there were all on the smaller side, and that the duration of time was anywhere from about 14 months through 32 months after placement of the device. There's the methods of removal. Most of them removed with endoscopy, some of them removed with laparoscopy. John Lipham's group then took that further, and they went and looked at both not only the MAUDE database, but they had the Thorax database available on all the worldwide removals. They took a look at the 9,453 LINX patients worldwide over a decade, and identified 29 erosions at that point in time for the current rate that we know of 0.3%. And again, John's data confirmed the same thing that C. Smith did, which was dysphagia and chest pain are the most common presenting symptoms that patients experience. And you can see the time frame of erosions on the right there, that most of them are between 1 and 2 years, some at 2 to 3 years, and then it starts to taper off. They went on and looked at whether erosion was influenced by size, and you can see that most of the erosions, 18 of them, or 5% of the total group, were in the bead size of 12, which has subsequently been removed from the market. So that device is not even available anymore, and hopefully that will reduce some of the erosion risk that's been going on. They also took a modified sort of Kaplan-Meier looking at the erosion-free probability over time, and you can see that the risk of erosion diminishes with time, but that curve hasn't flattened out yet, nor has it continued downwards, so we're not sure whether we're going to continue to get less erosion over time or we're going to sort of sit flat and see what happens. So I think more to come on the erosion risk over time. If you do get an erosion, this is Dr. Bonavina's paper. He talked about 2 various methods for removal. One is a 2-stage removal with an endoscopic cutting, removal of the exposed beads to allow mucosal healing with subsequent laparoscopic removal of any remaining beads at a separate time. And early on, the Olympus loop cutter would certainly be one of those things that you could use to cut the early LINX device. But now with the 1.5 Tesla device, using the Olympus loop cutter is going to be a much bigger challenge because the endoscopic cutter is probably not strong enough to cut that wire. In the 1 stage, there was removal of all beads, which might lessen the need for TPN and facilitate anti-reflux surgery. That depends on whether you can get all the beads out or not, so whether you could do that. In John's paper, they went on and looked further at the various ones, and the vast majority of them were endoscopic partial removal with delayed laparoscopic completion. 9 could complete it endoscopically, and so I think you need to tell the patients, look, we might not get all the beads out. The chest x-ray on the left is one of the erosions that we've had, and we left 8 beads in there that we could not get out after an endoscopic removal, and so did a 2-stage procedure. The nice thing about the 2-stage procedure is if the patient, you actually get a chance to see what the patient's like without the device in, and if they have no reflux, you might just want to take out the beads. Some patients will want to go on for a partial fundoplication or a fundo, but at least you can do that all in one second sitting. For those with a 1.5 Tesla device and nothing else works, I'm thankful that I have good GI colleagues, much like everybody else here is talking about a team affair. Jack Brandenburg is my GI colleague, and we had one of these 1.5 Tesla devices that we could not cut, and so we used the endoscopic lithotripter device. You can see that we've passed a wire through it. We've extracted the wire in the middle top box and brought that out and applied the crank wheel down around the device, and we snapped the wire fairly simply. That device works very well, very simple. It's not an added cost. People are talking about using the Ovesco clip remover to do it, but that's an added cost that if you don't have it in your shop, the lithotripter I think a lot of people have and was easy to use, and it's a reusable device. So that's our go-to at the present time. And if we talk about the second most common reason to have removal, it's reflux. And this is results from the PAS trial that showed significant improvement on all metrics of the Demeester score, and that was one of the highest rates of normalization of the Demeester score in the literature until we published the Caliber trial that Reg did not that long ago. But this was 74% percent time pH normalized, and the Demeester score normalized in 72% of patients. Well, if you average that over 200 patients, we would expect that in that trial, about 55 patients should have had a positive pH test, And would they actually all need PPIs? Well, the interesting thing is about half of them really only needed PPIs. 12.5% were on a PPI in this series. A third of them took it once in a while. 45% were on daily PPIs, and a smaller amount took it twice a day. So just because you have a positive pH test doesn't necessarily mean you're going to have symptomatic reflux in this population, and I'm not entirely sure why. We do know that reflux is related to the ability to restore a lower esophageal sphincter. This is some data that we put together a while ago. If you have a defective sphincter, you heard Dr. DeMeester talk about 1 defect, 2 defects, and 3 defects, the ability of the device to normalize that sphincter is less and less with the sphincter getting worse, and those people where you could not normalize the sphincter had a higher rate of reflux. Similarly, we looked at closure of the hiatus, which is where John Lipham's group has gone as well. It's a primary dissection out, reestablish length, and if you do that, you have the highest rate of achieving normalization of the DeMeester score. But you'll notice in this graph, when you had a hiatal hernia that was over 2 centimeters or at least 2 centimeters, our ability to normalize reflux not quite as good as if you didn't have a hiatal hernia. This is John's data again that was shown by, I think, Dr. Bonavina yesterday, showing that if you do full closure, you have certainly less persistent hiatal hernia, less reflux over time. And when he looked at those with less than 2 centimeter hiatal hernia, really if you do minimal dissection closure or minimal dissection technique, you end up with more recurrent and persistent hiatal hernias and still a higher rate of delayed onset reflux, suggesting that that closure of the diaphragm certainly has a role to play here. And then certainly this is one of my cases that we did early on, and we've looked at the deterioration of the hiatus. You can see these are a series of one-year endoscopies because he's part of the PAS trial, but over time his hiatus has deteriorated, and we now have positive DeMeester scores on 2 days. So I wonder what that means over time. The management of post-MSA GERD, PPIs, most of the PRNs, some daily. Very few patients wish to remove an MSA, and I think it's fine to have a combination of things going on. If they're taking PRN PPIs, they're usually taking way less than they came in on. And once in a while, we'll repeat pH manometry, and rarely have we converted anybody to a Nissen or a Toupet. I would be remiss if I didn't make some comments about the nationwide LINX recall that was put out in late 2018. We know that these are the affected lot numbers. This is a patient of mine, 1 year post-MSA, normal DeMeester scores intact. She came back with new onset reflux 5 months later, and you can see that the device there on the right is completely separated with new onset reflux disease. 18 devices in the world out of 9,000 have been identified as being part of the recall. All but 2 of them have been removed as of yesterday when I talked to Torax. And you can see that what happens is the little strut that's between the 2 beads comes detached. You can even see in the middle column, the operative photo, there's a little ball there. That's what completely became detached on the patient that we took it out on. These are some of the questions the patients have posted online. You know, if I have this later in life, will it be covered? I'm told by Torax that yes, if it develops down the road, we'll still cover you. And if I was a part of one of the LINX studies, will it be covered? The answer is yes, too. So I think you can reassure your patients that Torax is going to try to take care of them if it occurs. And if you get no onset GERD, chest x-ray probably is one of the first things you should get. Lastly, a few comments about some other things that we have seen over time. This is an elderly lady done by another surgeon referred to me to look after who's got a transmediastinal herniation. With pretty bad reflux disease, wasn't on PPIs. We put her on PPIs. This was a large paraesophageal that was placed. And as many of you know, Dr. Bell, Dr. Buckley have been studying large hiatal hernias and LINX. And at their 6-month visits or 6-month follow-up data, they had 4 out of the 51 patients who had been seen had a transmediastinal herniation for a rate of 8%. But I would also remind you that Dr. Oschlager's paraesophageal hernia data also at 6 months had a rate of 8%, and many of the surgeons know that that rate was 50 by the time we finished. So I think we're all eagerly awaiting the final results from Dr. Bell and Dr. Buckley to see what their 3 and hopefully 5-year data looks like, and hopefully it will be better than what we have currently. The options, if you have a herniation, I think PPIs to start with. You can redo the hiatal hernia repair, leave the device intact. You can redo the hiatal hernia repair, convert it to a Nissen, and you can also recite a magnetic sphincter. I think it's patient dependent, what you might do and what the anatomy looks like. We have seen rarely a new motility disorder where they do develop pseudoachalasia very quickly. Simply that is just removal of the device, sit tight and wait. And then we have seen new onset delayed gastric emptying, for which the question is that vagal? And I think Dr. Katzka raised some of the interesting questions about that. And so ongoing management of the gastroparesis is there. We haven't done anything yet with this patient because he's been symptomatic on medical management. So, and then this is a patient of mine post-viral gastroenteritis at 5 years, just before his 5-year visit, got into severe vomiting and managed to push his links up into the chest. He was mildly symptomatic after the episode, a little bit of discomfort, but PPIs and some time have solved that, and he's come back off of PPI. So even though the Lynx device is in the hiatus and in the chest, he seems to be doing okay with it there, and I have not taken it out yet. We'll just follow him carefully. So what can I tell you? Post-magnetic sphincter augmentation complications are uncommon. They usually occur in the first 2 years, but some late events have occurred. Dysphagia and reflux are the most common things that we end up dealing with postoperatively. Erosion is uncommon at 0.3% and presents predominantly with dysphagia and some chest pain, and usually can be managed endoscopically or in a 2-stage procedure. And if you do get new symptoms, I think you should be evaluated very much like Dr. Pandolfino outlined. And that's all I've got. Thank you.